Welcome to the International Association for Adolescent Health Pioneers Project. In this series, we have interviewed a range of experts from around the world who have led the way in promoting adolescent health in their countries, regions, or internationally. We wanted to listen to their stories and share their experiences so that these might be applied elsewhere. The members of the IAAH Education Committee were particularly interested in how these pioneers influence the education and training of healthcare professionals in adolescent health. In the following interview, Dr. Elizabeth Bankah is talking with Dr. Anthony Enimil, a pioneer in adolescent health in Ghana.
Hello, everyone, and welcome to our International Association of Adolescent Health Pioneers Project. And my name is Elizabeth Bankah from Ghana. I'm a family physician and a member of the Education Committee of the International Association of Adolescent Health. And today we have Dr. Anthony Enimil, who is a pediatrician and a specialist in infectious disease in Ghana, and has done some wonderful pioneering work with adolescents. So I will just hand over to Dr. Enimil. Dr. Enimil, please give us a little bit of introduction about yourself, and then we can go on.
Yeah, thanks very much, Betty, for this wonderful opportunity. I'm grateful. Yeah, my name is Anthony Enimil, as you mentioned, an infectious disease pediatrician and a lecturer at the University of Science, Kwame Nkrumah University of Science and Technology. And as you said, I have been working in HIV world since the past 20 years, specifically since 2004, and still growing within the HIV, TB, adolescent world. I'm married to Melina and I have 3 daughters. So I think this is a brief introduction about myself.
Okay, thank you, Dr. Enimil. So we would like to know about your personal journey and what inspired you to take up care for adolescents. You're a pediatrician by training, but then you went on to take care of adolescents, especially in this very important area. So could you tell us what inspired you to go ahead and do that?
Again, thank you very much. Yes, so yes, primarily I'm a pediatrician, but we just need to know that children grow to become adolescents. So you don't have a plan for adolescents, then the work that you might have done as a pediatrician goes to waste. So what motivated me to start adolescent health in children or adolescents living with HIV was because in most of our facilities, pediatricians see children up to 12 years, maximum 14 years. And by the age 13, 14, the children are moved into adult care. That seems to happen a lot. So we had a first set of our adolescents or our children who had HIV because they were antiretrovirals and they began growing. They were moving past the age of 12, 13 and then becoming adolescents. And we realized that they were not comfortable moving to adult HIV clinic because, again, at that time, the perception was people who have HIV had it through sex. And these were young men, young boys, girls, 10, 11, 12, who had it from mother to child. And they had not even had sex before. Yet, because they were HIV positive, there were plans to move them to adult clinic. And that is what inspired me, that why don't we begin to put them together as a group and then nurture them till they are matured enough and to understand why they are or living with HIV before we hand them over to adults. So that was actually the starting point. When children were becoming adolescents, living with HIV, we didn't just want to leave them because they were not comfortable in where they were entering, because most were adults who had had it through lifestyle. But these were children who knew nothing about sex, yet they were having HIV. So that was actually the starting point, the motivator that has actually brought us this far.
Oh, okay. Thank you very much. So as we know, pediatrics had always ended at 12, and then you know that pediatricians get attached to their patients and wanting to see them do well as they've survived up till that time. So So considering the health system where, as you mentioned before, pediatrics ends at 12, what were some of the challenges that, you faced having to keep patients not, older than the stipulated age for pediatrics? What are some of the challenges?
So it really started with engaging the head of the unit, child health, and then made a strong case that we needed to really consider these children as an entity. More of using the definition of children up to 18 years in Ghana rather than just transiting them, because they had a special condition. I mean, being born with HIV comes with its own stigma. And again, we made a strong case. Few of the children who had ventured to go into the adult clinic were so uncomfortable, and it was obvious that they didn't fit where they were. So I had a buy-in from the head of department, and then we started gradually mobilizing them. So immediately they turned 12 going to 13, we didn't allow them to see adults. We started gathering them into the adolescent clinic, and then it took off smoothly. So initial challenges when it went out of what was normal in terms of 12 must move. Yet there was a commitment on my side. And then one of the nurses, she's called Abigail Ameya. Actually, the two of us started because, again, I needed a female. I was the male doctor, a female nurse for us to come together. And we started with just about 3 or 4 young boys who were turning 13 into the clinic. And that is actually how the whole thing started.
Wow, that's very good. So basically, this wasn't available in the whole country. You are the pioneer who started this adolescent HIV clinic in the country. So being a pioneer, you have witnessed many changes in the field of adolescent health. You leading the course with HIV. So can you share with us a little bit about how it has evolved so far, as far as adolescent care is?
Yeah. So, when it started, medications were not as simplified as it is today. Now, most adolescents are on just a single tablet, which is good for them because they've grown into children. They are now in SHS, and it's easier. When we started, minimum was taking 2 tablets in the morning, 2 tablets in the evening. And for a child who is 10 years and suddenly being asked to take 4 tablets a day, not knowing even what he or she had, because most of them didn't even know they had HIV. They just knew that there were some tablets that they were supposed to take, they were supposed to package. And even for them, when they came to clinic and you asked them, so did you take your medication? They will ask you, why should I take medication when my siblings are not taking medication? So actually, from the patient's point of view, they really even didn't understand why we were asking them to take medication. And for few who had lost a parent, a father, a mother, because those days, they had a lot of parents had died. And it was just like in some East African countries where the child is survived by a grandmother or a grandfather because HIV had killed both father and mother. And today it doesn't happen because most are on medication. But at that time, you have a child 10 years, 11, 12 years who really doesn't know how he should take medication, supported by a distant grandmother who also sometimes even doesn't understand the full picture. So dealing with them as individuals was a bit difficult. And also creating space, even in the hospital setting, because again, it wasn't very popular at that time because most people didn't have adolescent clinic. But again, antiretrovirals were fairly available and their lives were expanding. So we took the bold step. That was in 2010, 2011. That was when we really started adolescent HIV clinic. And when these children were invited to clinic, at the start, one of the major challenges was, well, they didn't even have money to come to the clinic because, yes, some have lost parents, then the grandmothers were in mind. So we needed to have a motivation. When they come, we needed to foot even their transport and snack out of pocket. Again, these were all to motivate them at the beginning, early 2010, 2011, which and nobody knew about it. But again, we're making the case. So I remember in one of the National AIDS Control Program activities, we sent a picture of the group that had just begun. Very youthful, 13, 14 years. So about 8 of us, myself and Abigail, we were there together with them. And then even the National AIDS Control Program, they began to be aware that, yes, this is relevant. We can't just leave the adolescents that they have 10, 13, 14, therefore they don't belong to pediatric care. We should push them into adult care because of there was a gap. Either you are pediatrics or you are adult. So they began to understand and then started supporting, understanding that, yes, this is an entity. Let us begin to recognize them as a group because they are developing secondary sexual characteristics, which if you don't put them together for them to realize that they are lives. And again, what works well is they begin to know that they are not alone. And then the numbers started increasing. And we have laced our clinic with a lot of activities. So they tend to come together. And then we have specialists who will be doing, and I'm sure we'll be coming to that later. But for now, that was how we eventually built up, despite the initial challenges. I mean, they will come and if you don't give them money, they will tell you we won't come for the next visit. So you need to pay for their transport and give them something. And I mean, we haven't had formal funding from anywhere. It's just through our own innovation and making sure things will work in the interest of, as you said, these are kids. We have seen some as early as 1 year, 2 years. Now they are between them 14, 13, and then you just leave them to really go back. It was a challenge, but we held them on, and that is how far we've come.
Yes, very good. So can you tell us a little bit about, I know that you've done more for them, for the adolescents, as far as even vocationally helping them with their livelihood, helping to change, at least impact their socioeconomic status. Could you tell us a little bit about that and what you've done?
Yes, so we see the adolescent group as more of a family than a doctor-patient relation. So we try to fill in most of the gaps that they feel. And one of the things we started doing early was to recognize them as their own. I mean, they should take care of their own destiny by making sure they have leadership. So they have a president, vice president, other executives, and we just advise them, make sure that they have their own leadership who would work with us to achieve their purpose. And then we also formed a platform where majority of them are, so that those who cannot come directly to us in terms of the management team, myself, my nurses, and a few friends, actually friends have come together as early as the 2011s to form more of a management team, which really the hospital to some extent knew about it, but it was mainly handled by us. So we got teachers on board, we get pharmacists on board, we brought on board religious leaders and all the people who would have a role in the lives of these young people. We come together and we get to know those who are interested in education. If you're interested in education and for one reason or the other, there are challenges, there are people we call upon to help support you through your education. So there are shadows where we visit some of them in JHS, we visit them in SHS when school goes on section, especially those who have nobody to visit as a parent. We have a shadow where our members will go and at least let them know that they have people who are ready to support them. And when their results are in, and we realize that some didn't do well, then we make arrangements for us to let them choose their profession of interest. And we will go and negotiate with the trainer so that we make a payment and then make sure that they are really going to school. And it's worked for quite a number of them. For those who are able to go to tertiary, we do our best to facilitate, really to get them into the university so long as their cutoffs are good. But generally, what we do is annually we have a get-together, more of bring everybody around December. And most of our program, we add some award to it. So, I mean, the last year, those who have graduated from SHS, we really had just an award for each of them. We had an award for the overall best in their group during the SHS examination results. And then there was a second best. And then according to aggregate they've got. So all those who graduated really had some prizes, but we had an overall for the one who had the best aggregate out of the lot. And we work with them. We follow up on them in school just to make sure that especially the females, because they are likely to be victims than the males. So most of these are channeled through their leaders. And if they have any concerns beyond the leaders, then they will share it with us and we raise funds to support. The biggest challenge we have is actually they taking care of their viral loads. Viral loads are actually taken care by the national program. But because of the antiretrovirals, we need to do regular liver function, full blood count, and all that. Unfortunately, these are not covered by the national program. And so we have been able to lobby for some funding, and we have in excess of probably 30,000 plus currently, which we draw from. And then we keep adding on based on fundraising that we do. And for those who genuinely cannot pay, we make sure the labs are done for free, and then we pay it out of our own interest. We have also gotten one of the labs who really understood us, gives us rebate. So the nurses will make sure the samples are taken, the results are ready, and then we fund it from our youth account we have for the adolescents and young adults living with HIV.
Very good. Wow, Dr. Enimil. So not only are you taking care of them clinically, but socioeconomically, even affecting the social determinants that affect their outcome and helping them to be, to do well in the future. You really are doing a great job. We really, hats off to you. So I was wondering, since you are the pioneers we've talked about, are you basically, let's say, cloning yourself? I mean, training other workforce or health professionals to be able to do what you're doing, to be able to replicate this sort of holistic care that you're giving with young people living with HIV?
Yes, we do that effectively. Because of the initial work, I've had the opportunity to work at the national level with National AIDS Control Program. And they supported me to really develop a constitution for adolescents and young people living with HIV, which has been completed and shared with them. So there are regional organizations of youth living with HIV. And for most of them, through the support of the national program, we do trainings for them. We share our models with them. And within Kumasi, it's more organized, but we are based in Kumasi. So we have a group in Kumasi South. We have a group in Tuntre. We have a group in Lucia Hospital. All of them putting the young people together living with HIV. And then the model that we started with, we really keep teaching them just the basics of getting to support young people living with HIV. It is not much. The economy is a bit difficult and sometimes challenging. But having said that, we keep building their capacity as much as possible in identifying the unique challenges of young people living with HIV. In our setup, we have actually gone beyond the adolescents because we have a transition where between 10 and 19, they are in the adolescent group. And by the time they turn 20, we move them to the young adult group. So we have a group for 20 to 24, so overseen by us. By 24 years, we would have groomed them enough, and then we hand them totally to the adult physicians. But in the young adult, 20 to 24, we really work closely with the adult physicians, but we also take part, and then we finally bid them goodbye once they turn 25, and then they are totally in the hands of the adults. And so there is opportunity for those within our catchment area to learn from this model. And as I said, in Kumasi, for instance, the significant clinics all have started the same model, and they are just doing as we have been doing.
Very good. I heard about that. You actually were invited to the US to present your model. So congratulations in that too. Yes.
Thank you very much.
Yes. Okay. So could you share with us basically about 3 essential key topics for training that you'd want, other pediatricians or other people who work with adolescents with chronic illness? What would you like to share with us?
Yeah, most importantly, we need to recognize that they are still highly stigmatized. I mean, HIV prevalence incidence is low in Ghana. We are doing about 1.6% prevalence. Yet, I mean, probably because the numbers are very few, people think people with HIV are not in their family, people who don't even know anything. So the stigma is still very significant. I mean, unlike South Africa, where it is high, so you are likely to have a relative living with HIV, so you are likely to be more compassionate. We realize that people, so one of the things that we think awareness should be created is to accept young people living with HIV. I mean, whether they got it through their lifestyle or from mother to birth, from mother to child, the reality is they are Ghanaians. They have the infection. I mean, you don't get the infection by speaking to them. You don't get the infection by just handling them or hugging them. But I think there's a wrong notion. And we've had instances where some landlords, just by getting a hint that somebody has HIV, are ejecting them from their homes. So I think one of the areas where we should begin to preach or let people know the fact that, yes, they may be having HIV, but in fact, this time, if they don't tell you they have HIV, you will never know. Because physically, they are just like people without HIV. And let us realize that it is our responsibility to keep informing ourselves that they must be loved just as we are loved. So that is one angle, just making sure that we reduce stigma. As much as possible, they are also, let's understand that they are growing. They will go into relationship. There's the need for us to recognize that they have sexual needs like even those without HIV. Sometimes we tend to ignore. You think, well, you have HIV, so don't marry, don't go into any relation. The good thing about the disease now is so long as you're on your medication and your viral load is suppressed, you are almost likely not to transmit. So it's no longer as fearful as it is. So let's begin to accept them as one of our own and then make room for them and then support them as much as you can in terms of the relationship. And then the third aspect is we need to really make room for them to be employable as well. It's becoming more difficult in the African setting. And if we are not careful, they become a burden. And then in line with becoming a burden, they are becoming victims. So you have a young lady, 22 years, who is living with HIV, yet is not empowered with any skill. The temptation to go into relationship with a man, not because she really wants, is high, because then of the vulnerability. So really, there should be opportunity for capacity building. And as much as possible, we should offer them the opportunity. We, the trainers, that, look, if you can't go to school, there are a lot of other opportunities to build your skill. Hairdressing is a very typical one that most of them want to be in, dressmaking. So if we are able to understand that they are growing, they are not different from any other person, but they have needs. Just because some of them have lost father, mother, the community should understand and support their needs. But sometimes they toil in because nobody is ready to help. But if we approach them and give them the options, we realize in the cohorts, they open up because they wish. I mean, nobody will say, I wouldn't want to do anything, but sometimes opportunities are not offering themselves. And we have identified a few who have made it academically and also even making it vocationally. At least the little that will take care of themselves and for their own immediate family once they marry, it's working for them. So I would think we talk about three main areas. These are my three top things that should build capacity and help them to develop.
Oh, thank you so very much, Dr. Enimil. So, last question. Could you please share with us your vision for adolescent health and then training in adolescent medicine or adolescent health in the future? That would address all of these because you've really done a very wonderful, holistic, comprehensive model.
Yeah, you took the word out of my mouth. I was going to say, taking care of them should be holistic. Let's have a plan. It's not just taking one aspect, like, well, you are on antiretroviral, let me prescribe it and go. No. If you do it that, you will pick the medication, but no, they will not even take it because they may not even have food to eat. So let's see them as a complete entity, and as much as possible, let them own their program. So what we do is most of the leading is not done by the medic or me. It's done by their peers, their leaders. They make announcements. They make sure they mobilize them. If there's a meeting, I don't play any role. They mobilize them and bring them. Once they identify it is their own, it's not like we are pushing anything on them. It is easier to get them. And then we give the opportunity to tell them their needs. Exactly what do you need? And how do we engage you? In a number of the research that we do, they are all the research. We either use them as research assistants. So they are part of what is going on because it's about them. And once they know that really we are not taking advantage, and that is what sometimes they think that, look, you are doctors, you are not positive, and you just want to use us as research. No, they really are part of what we do. We often take their input in even designing some of the things that we design. So I think the key word is, let's not look just because we are giving them medication as their doctors. Beyond the consulting room, consulting is probably just about 10%. 90% is in the community. The interactions they have, they go to school, they are in boarding school. I mean, those in boarding school are taking medication in the context of boarding school. And if you really don't keep your eye on them, a lot of things can happen. I mean, very recently, as recent as a week ago, I was involved in one of our 20-year-olds in one of the schools in Kumasi Secondary School, who inadvertently did not take his medication seriously in terms of preserving it from being seen. And then one of the students saw the tablet, the box, the bottle, with the label on it, and then read it, Googled, and realized it is antiretroviral. And it caused a big scare. So the headmistress got to know. So the child, that lady and the mother came to me, and I said, well, for this one, these are instances where, again, the girl was so stigmatized that she doesn't really want to go to school anymore. And in this day of social media, I told her, look, even if you go to another school, it's just a matter of being finding out and then sending a message that this girl left our school because we found out she was HIV. So this was a journey I personally took to meet the headmistress with her mom. And then I told them, well, it has happened, but we need to do damage control. So I made them aware that these drugs, tenofovir and others, they are not only for treating HIV. It could be used for other conditions. So the plan was for the headmistress to go and speak to them. Yes, you found this drug, but don't associate it with HIV because other conditions are used. So she told them this girl has a chronic condition. The medication may overlap with this, but it's not necessarily HIV. She shouldn't hear anyone say that because she has her own condition. Others have their own condition. And we negotiated this, and it's gone well. So this is where it's outside my consulting room. If you don't go to the school to really use your professional skill to tell them that, look, other conditions use them, it would have damaged the girl's future permanently. Because social media will tag you forever, and then now it has gone down. They are not talking because they have had explanation that there are other conditions. In reality, we know it's HIV, but judging the level of stigma, you wouldn't want to destroy somebody's life permanently. And it's working. So it means that for patients, if you need to leave your consulting room because this thing I'm talking about is a community school setting, but it has impact on her treatment and her mental health. So if you don't tackle this as an entity, complete person with dangerous on their relationship, we intervene in their relationships all the time. We are interested in people they are going into relationship with. A lot of them will come and tell me personally that this is the person I'm going out with. If I need to do any intervention, making sure you are suppressed, we talk about that. But these are things which goes beyond just the consulting room. So as clinicians, let's go beyond writing tablets through the journey of adolescents into young adults and ultimately into adults. That is what we are looking up to. Thank you.
Okay, well, thank you so very much. It is very refreshing that Dr. Anthony Enimil, the Pediatrician and Infectious Disease Specialist, takes care of the biopsychosocial needs of the adolescent in a non-reductionist manner, where you are seeing the child or the young person holistically and really not only clinically, but then also psychosocially, socioeconomically, and everything in between. Thank you so very much. And God bless you for pioneering in this. We hope that we will have more of you as you continue to train the residents, pediatric residents, continue to train medical students to follow your footsteps, to really bring good health and a good prosperous future for our young people living with HIV. Thank you very, very much. And thank you for being a guest on our International Association of Adolescent Health Pioneer Project. Thank you very much, Dr. Enimil.
Thank you very much for the opportunity. I'm sure we'll have opportunity to talk again. God bless you.
Thank you.